I'm honored to present today with the cleft Smile Train and West Africa College of Surgeon. As you know, we are working on children, and with Smile Train, there is guidelines whereby a child needs to be operated when he has really a good weight for age. So I'm going to present you one of my research in Uganda, entitled is birth weight associated to timely attainment of minimum weight for surgical correction, cleft lip and or palate. It is a study. So this is the plan we want to follow today. I want to introduce, and then we'll have to set our objectives, and then we will talk about methodology. Then we'll present our result, and then after we're going to discuss what we found as a result, and we are going to conclude. So a cleft lip is a congenital defect in the lip between the nose and the mouth, resulting from incomplete fusion in the lip during embryonic developments. And it can be unilateral, like we see on this picture, or it can be bilateral. It also can be incomplete, or it can be complete. On the other hand, the cleft palate is also a congenital defect in the roof of the mouth, resulting from incomplete fusion of palatal shelf during embryonic development. And this can range from the opening of the soft palate only, as you can see on this picture, to the entire opening of the roof of the palate. And this cleft palate can be associated with a cleft of the lip, and it can be unilateral, as you can see, or it can be bilateral. So cleft lip and palate are common birth defect, affecting about 1 to 700 newborn in the world. However, there is a variation in prevalence across geographical and ethnic region. And in Uganda, the incidence is about 0.73 for 1,000 births, with an estimation of about 1,100 newborn per year. And cleft impose really a large burden on health and well-being through life. Cleft condition is associated with several factors that will influence growth. And among these factors, there is low birth weight, there is infection, and also other associated abnormalities. According to UNICEF, in East Africa, we have a prevalence of 13.5% of low birth weight, and in Uganda, it is 12%. So early correction of cleft lip and palate would result in reducing early malnutrition, and it will enable these children to be able to feed and benefit really for breastfeeding. But although there is surgical services available in Uganda, infant will be really fit for surgery when he will have at least 12 weeks, which is 3 months, and a minimum of 5 kilograms. But attaining this minimum weight is really a reason, has been a reason to delay surgery, because some of the patients will not attain these 5 kilograms at 3 months. And based on cost statistics, we found that 68% of children will not attain this 5 kilograms, and this will lead again to a malnutrition and risk of death, and also recurrent infection. So despite the fact that infants with cleft lip and palate will have 2 times the risk of low birth weight as compared to those without, the extent to which low birth weight impact on attainment of minimum weight for surgery is not known, especially in Uganda cleft infant, That's why this study set out to explore whether there is an association between weight at birth and attainment of minimal weight for surgery. We focused on weight because surgery as early as this will potentially grant the infant more benefit from optimal feeding and may potentially avert early onset of the malnutrition. So we think that the result of this study will help to support early detection by midwives, gynecologists, pediatricians, nutritionists, medical officers, and also surgeons to detect all these cleft lip and palate newborn at risk, and also with delayed attainment of minimal surgical weight, and then advise maybe an early intervention. So our main objective was to determine the association between weight at birth and then minimum weight required for surgery and other associated comorbidities in cleft lip and palate in children with 12 to 16 weeks. This is 3 months. And we set out some specific objectives. The first one was to determine the proportion of infants with cleft lip who attained and those who did not attain that minimum weight for surgery. The second specific objective was to establish the association between birth weight and the weight for surgery. Portion of these associated abnormalities in cleft lip with or without minimum weight for surgery. And we did an unmatched case control study for a duration of 9 months within this period, and it was done within the plastic and reconstructive surgery unit at Coast Hospital in Uganda. And we included all infants who with the age between 12 to 16 weeks and with the body weight measured between this time period, and who had evidence of birth weight record, and of course whose parents have consented to this study. And we excluded all infants who had partial correction of cleft lip and palate before the enrollment into our study. So we defined our population as infants between 12 to 16 weeks, and we defined cases, all the infants who had less than 5 kilograms between 12 to 16 weeks, and then the control was infants who had 5 or greater kilograms between 12 to 16 weeks. So we calculated our sample size using a Kessler formula for binary outcomes, and the required sample size was about 102 participants. However, we're going to see that we had 100 participants, and we did ethical consideration. We had approved clearance from Bara University, and then we had also approval from Coastal Hospital, but also a record and informed consent was given to the mother and parent and caregiver of the infant who accepted to be enrolled into our study, to confirm their decision to participate into our study. So for data collection, we once the caregiver was admitted in outpatient or even in inpatients, what he was told about the study in the language he understood very well, and also the informed consent was given to this caregiver or parents for both cases and control. And then we collected data using a questionnaire, and the questionnaire had different sections, among which the socio-demographic factors, data of the caregiver, but also the infant-related factors, and then the nutrition factors. We did a physical exam in infant who was enrolled, and then all the information were recorded. To complete the data, the weight of the child was taken, and we took the weight of the child without diapers, without clothes, on a digital machine at 0.01 nearest kgs. And then this is just an example of a weight scale, which is a digital one, which can give us the number of kilograms and also the grams. So I've said already this, because we had the socio-demographic factors of both the mothers and our caregiver, and then we took infant related and nutrition factors, and then we did physical examination, and then lastly infant weight. So data obtained was entered into APM4 version 7.2, and then it was transferred into SATA version 13.3 as our dependent variable. And for this, we defined normal birth weight as the birth weight which was greater or equal to 2.5 kilograms. And then we define low birth weight as birth weight less than 2.5 kilograms. This is according to the WHO rules. So we did chi-square tests, and logistic regression was performed. We did univariate analysis and also multivariate analysis for our data, and then we express as adjusted and unadjusted odd ratio. We considered an interval of 9.95 0.05 was taken as significant. When you see the nutrition baseline, we could see that overall, most of the patients had complementary milk, and most of them used a squeezable bottle, and breastfeeding in 58%, and then cup and spoon was used in 85%. Most of the patients had also spillage. Choking was also present in 42%. Among cases and control, we can say that majority of cases, these are those who did not attain the weight, used complementary milk, and then also they used a squeezable bottle. And spillage was present in all the cases as compared to the control. So to respond to our first objective, which was to determine the proportion of cleft lip and palate who attained and those who did not attain, you can see that for a sample size of 100, 39 did not attain the weight required for surgery versus 61. And among these, we could say that 27 had a normal birth weight. However, 12 even did not attain the minimal weight for surgery versus 3 of control. And when we see the cleft type, we could see that cleft lip and palate did not really attain the minimal weight for surgery, and followed by palate only, and then lip only. To answer our second objective, we could say that although there were not really strong association as the p-value is greater than 0.05, but we could see that the odds of not attaining minimum weight for surgery were 3.4 among infants who had low birth weight, and also cleft lip associated with palate had odds of 13.19, risk of not attaining minimum weight for surgery as compared to those who had lip only. And when we see associated abnormalities, we see that infants who had at least one associated abnormality had the odds of 13 almost of not attaining the minimum weight for surgery after controlling for sex, cup and spoon and other associated abnormalities. To answer our third objective, we see that overall we had 12% of our patients had at least one associated abnormalities, and the abnormalities was really normally distributed among cases and control. However, we could say that 20% of cases, these are those who did not attain minimum weight for surgery, had at least one associated abnormality as compared to 4 for those who attained the minimum weight for surgery. And this is a diagram which shows that the distribution of associated abnormalities, and we see that head and neck was most affected, followed by heart, and then upper limb. This is just a picture to show one of our patients who had, if you can see on this picture, he had a hyperthyroidism, and he was really having issues in attaining the minimum weights for surgery despite the nutrition. This is another example of a child who was brought to us for 4 days with a birth weight of 2.3, and you can see that he has also other associated abnormality on the hand, which is a cleft hand and a missing finger here, but he had another extra digit which was already tied by the family. So to discuss our result, we can see that our first objective was to determine the proportion of infants who attain and those who did not attain minimal weight for surgery. And in our result, we found that 39% of infants did not attain the minimum weight for surgery, and cleft lip and palate was really the most affected. And when we see there is a relationship really between type of cleft and poor growth, it has been reported by Lazarus, who did a study to determine whether infants with cleft lip and palate are underweight for age at the time of surgery. And he found that 30.5% of children were underweight for age at the time of surgery, and cleft lip and palate were the more affected than isolated cleft lip. So we can see that this proportion is a little bit lower than our result. Maybe this is because Lazarus did not include all the infants who had other associated abnormalities as compared to what we did. So cleft lip and palate and isolated cleft palate are more at risk of not attaining minimum weight for surgery due to their inability to suckle the milk, and also this which have an implication in poor weight gain. For the second objective, which was to determine if there was an association between birth weight and attainment of minimum weight required for surgery. We could see that in our study, the proportion of low birth weight was 15%, which was 15 infants with low birth weight, which is also a little bit similar to the WHO of low birth weight among children in Uganda. However, we see that 12% of 15 did not attain minimum weight for surgery, and we've seen the result that they have 3.5 times the risk of not attaining minimum weight for surgery. And despite that, the fact that it was not really statistically significant, but we can say that it was a really clinical association between low birth weight and attaining minimum weight for surgery. In his study in Brazil, Mota et al. Analyzed infants with low birth weight, and he found that these infants with low birth weight were 29 times at risk of getting malnutrition in their life as compared to normal birth weight. So we could say that maybe the small sample size we had did not allow us to get really a statistically significant. For the type of cleft, we see that infants with cleft lip and palate were more affected with 14 times at risk as compared to those with cleft lip only, with the proportion being 79%. And Soriano in Cuba found that patients with cleft lip and palate who had low birth weight was predominant with 80.6%, which is almost not different from our result. When we see the association abnormalities, our result found that infant who had at least one associated abnormality was at least 30 times more at risk of not attaining the minimum weight for surgery. And in his study, Beaumont et al. Report that infants with cardiac abnormalities and airway difficulties like Pierre-Robin sequence have additional energy requirement in order to suckle. And infants with this type of abnormality will burn a lot of energy because of difficulty in feeding. And for objective 3, overall, the prevalence of other associated abnormalities was 12%. And we see that the head and neck were more affected as compared to other portions of the body. And we see that the proportion among cases was 20.5 as compared to control, which was 6.6%. Different study has reported these associated abnormalities proportion to be between 1.5 and 16.4. Like what found Adesina in Nigeria, he found that 11.5% of infants had associated abnormalities when he did his consecutive cleft lip and palate study. And Franklin in Iran found that 28% of his study had associated abnormality, and most of them had cardiac abnormalities. So the proportion is really variant, as you can see, compared to different studies. This is maybe due to maybe the location of the researcher, and then also the mean he's having in order to look for other associated abnormalities. So what was our limitation? We thought that the lack of birth weight for some other infants who came to us the evidence of death weight, we could not enroll them. And also some even who had the delayed first consultation, because we found that the majority of our infants came 9 weeks after birth. So this leads us to have a small number, and which may have an impact in the association we had. But also we couldn't do other cardiac echography or ultrasound, abdominal ultrasound for every children to really look for these hidden malformation because of the means. So so to conclude, we could say that low birth weight could be, it was not really statistically significant, but could be a risk factor of not attaining minimum weight for surgery. And infants who had cleft lip and palate associated with associated congenital abnormality are really more vulnerable. So we need really to look at this type of cleft. And then the high among infants who did not attain minimum ideal weight for surgery. So when the child is really coming to you as a patient, and when you look that he had low birth weight, we need really to look at other associated abnormalities. So what will be our recommendation? We could recommend that there should be an increased vigilance of cleft lip and palate infants with low birth weight and associated congenital abnormalities. And consider this really an early intervention, and intervention from nutrition, early malnutrition. We are happy that in our country now we have started and we introduced the nutrition program by Smile Train, and then we think that this will really enhance our management, and in order to capture all these children who are really having issues in growth, and capture maybe a large number of children, and then we should maybe advise that we could start looking for the birth following them. So we could also capture for other associated abnormalities. So we're going to finish this with something which is really a challenge. There are some infants who really do not attain the weight for surgery despite all the nutrition. I've seen this in Uganda, whereby you see a child who is having really a lot of malnutrition that associated with other associated congenital abnormalities. And these challenges, sometimes you're not able to operate on them. When you see the guidelines from Smile Train, you understand that it's really not possible. And I would like to hear from the audience what will be your approach when you see a kind of a child who's not really gaining the weight despite his age. Thank you very much for your patience, and I'm sorry for the inconvenience of the network. Thank you very much, Dr. Luke. That's all.
Oh, thank you very much, Dr. Obadi, for this very brilliant presentation, which was very well presented. Even if it was conducted in Uganda, I'm very certain the result can be extrapolated to other African countries like Congo, Nigeria, and all the ones which are represented here. So this study has been an eye-opener, so that when we see children with a low weight, we should try to dig more to find anomalies for the highest safety of our children. So that said, I have the first question here So Luzadi Kabuya is asking, he said, do you think, in French, pensez-vous que le fait que les cas représentent 30% de l'échantillon nous permettent d'en tirer de réelles conclusions? Do you think that since the cases represent 30% of our sample, can allow us to draw sound conclusions?
Okay.
Dr. Obadi, yes.
Yeah, thank you very much, Dr. Luke. I think we've responded to that question during our presentation. We had 100 patients, and among them 39 did not attain minimal weight for surgery. When we see, as we did a case and control, we could say that the ratio is 1 to 1.5, something like that. And this really, we really can't not tell. And also, you see our p-value was not statistically significant. But when you see the patient who was born with low birth weight, we had 15 patients with low birth weight. Out of them, 12 did not attain a minimum weight for surgery. I know it's really a challenge when a statistician comes in. They will tell you that the p-value is not significant. We can't really conclude and then extrapolate these result. So it's really a challenge, which is a clinical result we had. That's why maybe we could discuss and see among 15 patients, infants who were born with low birth weight, have 12 among them 12 did not attain minimum weight for surgery. So it's really a challenge. We had a challenge when we presented this result, and when we see the statistical side, it is not really significant. But when you see the clinical relevant, it's really statistically significant. So that's why I suggest that maybe we do a cohort study looking at the birth weight and then the weight at the time of surgery, and see if really we'll have at the end maybe of a large sample size, and then we can conclude to this result. Thank you.
Thank you, Dr. Obadi, for your answer. There is another question here. Mr. Jiche Ose is asking, he says, thanks for this great presentation. He asks, what do you suggest if the child, because of the low birth weight and associated abnormalities, and despite a good nutrition follow-up, definitely doesn't reach the weight requested by the Small Train platform scale? So he's asking the same question. Back to you.
Thank you very much. This is really a challenge. I will be happy if I know Smile Train advisors are maybe among us. They will help us to understand what we can do about these cases. But in my opinion and my experience, and when you see parents coming to you like several times, child are not really getting the normal weight for their age, they have cardiac issues, and then the mother crying, they want you to operate on these children. Sometimes we follow them up to 1 year, and then we send them maybe to cardiologists to see if they can also assess for these cardiac issues. And if the child is really fit for surgery, they will tell you that this child is not fit for surgery. He will need maybe a cardiac surgery first, and then we'll follow them. But when this cardiac surgeon, for example, has told you that there's no issue, you can go ahead with surgery. But when you will come back to the Smile Train guidelines, you see that it will not really fit into the guidelines. That's whereby you really have to challenge yourself and say, should I leave this mother with this child unoperated, or should I do something to this child? And sometimes you will operate on this child and you will not really consider to be part of a Smile Train cohort. And so you'll operate the child. Maybe you talk with the medical director of the hospital, and then you can give some means you to operate on the child. And this child will not enter the Smile Train database, because it will not really fit according to the guidelines of Smile Train. I know there is advisors among us that can also tell us more about what we could do. Thank you.
Thank you, Dr. Obadi. Unless there is a comment from the audience, I will go to the next question. The next question is from Stella Ogunmulwa. She said, I will read, I would like to know the answer posed by the presenter on the last slide. There are some patients with dysmorphism that just fail to thrive in spite of all the nutritional support given. Echo also reveals no associated cardiac anomalies, and patient has not attained the required weight for surgery. Please, what do you do for this category of patients? We'll also like response from Smile Train crew. So it is the same question, actually, the same debate remains.
The same question, yes.
So maybe as we expect answers from colleagues, there is another question from Frank Masumbuko. She's saying, en dehors de guidelines de Smile, que pensez-vous de la chirurgie précoce? Beside the Smile Train guidelines, what do you think about early surgery, meaning the repair of the lip at birth? I mean, at the first day of birth, or the palate at 3 months. Do you think this could prevent the nutritional problem, Dr. Obadi? What do you?
Thank you very much, Doctor. Thank you very much, and thank you, Dr. Frank, for this brilliant question. I know for the cleft lip and palate management, there are several protocols, and there's people who will prefer operating on children just at birth, and those who will tend to wait a bit. They have some of their reasons. People who will operate on children will think that children will have a good scarring for this, and also the children will grow up without maybe this deformation. It's also a psychological issue for their parents. They will see the baby really operated at early stage. And there are some studies, however, on the other side that will tend to wait a bit. Maybe this is why Smile Train has ticked on 3 months of age and 5 kilograms of weight. This is most of the time due to the security during operation. And I know anesthetists will give me a reason that the more you operate on less babies, the more you have a higher risk of having complications. And because these children will have coldness into the theater, they have less subcutaneous tissue, they will handle really this operation with many challenges as compared to children who have really gained weight, because they will also be able to support the anesthetic program sides. Sorry. So the other thing is that Smile Train has given maybe the guideline that lip could be repaired 3 months of age, and then palate after 6 months of age. I know it's really a challenge here in Africa to really understand these guidelines, because maybe in developed country you will not really find there's really good follow-up. Children will not have issues in maybe gaining weight. But here in Africa, there is also another problem of social issue at home. You'll find a mother with a 2 years old with a cleft, but he has had another child of 3 months after that. There is a social issue of getting food, getting milk. So these children will have really issues in getting. So it's really a matter of seeing the benefit of security of the patient to operate on children at younger age than in older age. For the soft palate, people will tend to operate on children as early as the child has started to speak, because we know that the palate is having a great, it's a great component in speech. So we'll tend to operate the palate before 18 months to cater for the speech. But also it may increase the chance to these children to be able to suckle and then be able to gain weight. Maybe we could do a study, like a cohort study in children who have been operated and follow them to see what will be the challenge. Are they gaining weight? Is it really helpful? And then we can conclude on that question. Thank you.
Thank you, Dr. Obadi, for your brilliant answer. There is another question here, Lusadi Kabuya, asking whether you have some experience in operating children with anemia.
Okay, thank you very much for that question. This is another challenge also we have. And when children are really having issues in gaining weight, they also have issues in having their blood level to be in normal range. And we know that Smile Train have given us a range of 10 grams as to be the cutoff. So you'll see that these children will really have issues. That's why in nutrition program, we'll have supplementation to really try to give these children the opportunity to heighten their level of blood. So they will have iron supplementation during the nutrition follow-up. On the other side, there is another challenge. I think I've really shared this challenge a long time ago. There are children who maybe are sickle cell, and then they will have really this chronic anemia. They will never reach 10 grams of blood level. I think this is really a management of a teamwork. Thereby, this is where the teamwork will decide to see, is it this child, even if he's a sickle cell, is he able to sustain this? And the nutritionist, the pediatrician, and together with anesthetist team, I think they will have to get a one-point view to see if they can operate on these children, because these children, they will never get 10 grams of blood level.
Thank you, Dr. Obadi. There is another question here from Duncan Musa Sizi. She said, dysphagia. I don't know if doctor could explain more about dysphagia. She said, because a child might have a good nutrition follow-up, but has dysphagia. She said, could you explain more about this?
Dysphagia, it's maybe, it means that children are really not able to swallow very well, and they're having issues. That's why the team management comes in. So children who will have issues in gaining weight, let us try to send them to the pediatrician. The pediatrician will assess them and then try to find out if there is an issue. We maybe in next time we will want to have ENT surgeon among the team who will be able to try to find if this child is not having maybe tonsillitis, which is sometimes common for children, and maybe recurrent infection. What I know that infants who will have issues is in gaining weight, they will also have recurrent infection starting from the throat and nose, ear, and then also lower pulmonary tract infection. So it's good to work as a team, try to find if this child is not having issues. What I know that children with Pierre-Robin sequence, which have really a slow jaw, a small jaw, they will have issues in swallowing. These kind of children, they are really, you need to really manage them early. And the first emergency for them is breathing. So these children, we will need to maybe follow them. Some people will try to do mandibular distraction to allow this lower jaw to come in forward, and then maybe allow these children not having issues in swallowing. Some people, at some points, for these children, you will use sometimes nasogastric tubes to allow them maybe trying to swallow, but we don't really recommend nasogastric tube, because this nasogastric tube will not allow the child to be able to swallow and to gain that habitude of swallowing. So a team management is really important for that.
Thank you, Dr. Obadi. Danny Loani asking another question here. What does SmartTrain recommend in terms of prevention among women who are pregnant, but whose nutrition is well balanced when during the pregnancy, so that children can be born with a good weight, so that they don't have issues with cleft surgery if they are born with a cleft lip or palate? As she says, it's better to prevent than to heal.
Yes.
So Dr. Danny from Kisangani.
Thank you very much, Danny, for this question. What we know, and this is really why SmartTrain is really pushing to have comprehensive cleft care within hospitals and their partners. And this comprehensive care starts from antenatal period, because we want to really diagnose the cleft when the child is not really born. So the obstetrician comes in to manage this. So we know that low birth weight has really many reasons for mothers. It can be a problem of placenta insertion. It can be also a mother health condition when the mother has infection like rubella, cytomegalovirus, toxoplasmosis, syphilis. These infections could really affect the baby's weight within the womb of the mother, but also the age of the mother, which is lower than 17, maybe greater than 35. And also, that's why in the SmartTrain, you'll find that there is some question whereby you need to ask if it is the mother a smoker, or does she drink alcohol during this pregnancy, and was she exposed to the metals? But also, you need to ask the mother if she had used before the pregnancy some drugs, or maybe during the pregnancy. There is some also disorders like high blood pressure, and also poor nutrition. Thank you for that, because the nutrition of the mother is really key. We need to really start counseling this mother about their nutrition, because it's going to affect the child they're carrying their womb. And also there can be another problem. A mother can be healthy but has an issue of the uterus. A uterus may be a small size. You may have to deliver a baby who have a low birth weight. So it's really important to counsel these mothers before they have really delivered, so that they can improve their nutrition, and try to find if they can see a nutritionist in our hospitals. And as I say, this is why Smile Train is really pushing for each partners to have a comprehensive cleft care in their centers. Thank you.
So far, unless I've forgotten a question from a colleague, it seems like Dr. Badi has answered all the questions. Correct me if there's any question, please type it again so that I may ask Dr. Obadi to answer. So if there is no questions, okay, I will hand the stage back to Smile Train, I think, for conclusion.
Thank you so much, Dr. Luke, and thank you so much, Dr. Obadi. That was a phenomenally well executed and very educative session. We wouldn't possibly need to repeat what Dr. Obadi had said with regards to our safety and quality protocols, because everything that he said is exactly what we do. Our children cannot get surgery unless they are 3 months of age. And equally so, they have to be at least 5 kilograms in terms of their birth weight. We really highly recommend that all our partners follow our safety and quality protocols as provided, because this is what is a matter of life and death for the patient. As well, for our anesthetists, they also recommend the same, because they understand the amount of drugs that would have to go into a child. And considering the safety that needs to be observed, we have to be very, very cautious and strict with our procedures. All the same, we do truly appreciate that we have nutrition programs that support our patients to make sure that they are able to reach the birth recommended for surgery. Even our mothers can go through that kind of training to make sure that they, when pregnant, they are receiving the best nutritional care possible, so that we do not have patients being born with cleft. Once again, I truly appreciate Dr. Malemo for such a wonderful moderation. Dr. Obadi for being very elaborate. Thank you so much. And to all our attendees for being interactive with your questions, your comments, your feedback. It is very encouraging. I look forward to seeing you next week. We have a very exciting session that will talk more about cleft care across the continent. My name is Emily Manjeru. This is Smile Train. This is the Telecleft Virtual Lectures brought to you by Smile Train and the West African College of Surgeons. Thank you once again for being with us, and we wish you a brilliant week ahead.
Thank you very much, everyone. And